Welcome to the Beverly Hills Plastic Surgery Podcast. I'm here with my favorite non-forehead flapped co-host, Dr. J. Calvert.
You don't need a forehead flap. It's just a little, it's a moment. It's going to be fine.
I'm feeling very self-conscious about this little zit that popped up on my nose, and Dr. Calvert told me I needed a forehead flap to cover it.
I didn't say that. Maybe I did.
He totally did. And that's okay. I told him he looked amazing.
It was in jest. It was funny. No forehead flap. It's funny, by the way.
For anybody at this table.
That's right.
If you don't know what a forehead flap is, that is great. You don't need to know.
No, you don't.
It's only for those who need to know.
When you know, you know.
When you know, you know.
And when you're going through it, we're on your team.
You're on your team.
We understand it is a big process. But anyway, I was just talking about it because we got some forehead flaps out there lately, so.
Yes, but not today. That is not what we are talking about today.
No, I like our topic today, and it's interesting because of what is our topic, Dr. Rovelo? Go.
Our topic is colloquially known as the internal bra or mesh or a biological matrix. All of these things are used to describe some kind of supportive device that we are putting into the breast for a variety of reasons, which we will go through.
Yeah, and these interesting because it's like they're not really, it's not their indication, like according to like FDA approvals and things like that. They're just devices that plastic surgeons have made work in these situations. And an example is and I just very, very quickly, I don't have any financial interest in any of these products. Neither does Dr. Rovelo. So we're going to talk about them pretty freely, and we're going to use brand names and whatever, because I don't really know that there are generic names for like Galaflex mesh or whatever. But the reality is that they're all indicated for soft tissue reconstruction, so they are FDA approved. But nobody's been there saying like, oh, we did a study with 200 breast patients. We found that the inframammary fold could be. These are all things that plastic surgeons have discovered, pushed forward, and have become what is known as the state of the art in the community, basically.
Right. And so these are devices, and there's a variety of devices that you can use. Biologic devices means that they come from some kind of formerly live biologic character, a human, a pig, a cow. And after that person, cow, pig, has died, they take the skin, they wash it, they strip it of all the live elements, and now it's basically just a matrix. It has nothing alive in it anymore.
Right, it's proteins and all kinds of different structural elements that don't have any living tissue in them.
Zero. But because they came from a living thing, they are called biologics. And those are under the brand name.
Wait, are they biologics or are they medical devices?
I don't know, we call them biologic devices.
Huh. Because I think they're actually classified as medical devices, which is why they go through a different, and we are like in the weeds right now, baby.
We refer to them as biologics.
Okay, whatever.
When we're talking about like, yeah.
But there's for those of you at home kind of like listening, or the FDA process to get these things approved is, the dare I say onerous is like an understatement of the century. It's really a big deal.
It's a big thing. So we have the things that formerly came from live structures. And then you have we call, their prosthetic devices, or what's what I'm looking for? It's not
synthetic.
Synthetic, that's the word, synthetic. So they've been made in a lab.
Right.
And there's several of these. The biologics, like I was going to say, under the names of Alloderm, Flex HD, different brand names, if you ever heard these thrown around. And then the ones that we use that are more synthetic are typically the Galaflex mesh, or some other brands out there as well. And those are devices that are made in a lab and then we use, again, for soft tissue support. All of these devices eventually absorb. These are not permanent meshes. We call them meshes sort of in our world. We call it a mesh. And they go into the body. The body starts to grow into them, incorporate. So it puts down blood vessels and collagen fibers into this matrix that's been placed there, whether it's a biologic or a synthetic. And over time, that matrix or that mesh dissolves, goes away. If you go back in 6 months, it'll be completely gone and filled with your own tissues. So these are not permanent structures. We've used them historically for things like hernia repairs in the abdomen. And so that's where people are kind of classically used to seeing them. And that's where they have, as you said, their FDA support. So they have FDA approval for uses for things like hernias, abdominal wall repairs. We have been using them in the breast for decades. Most commonly started in breast reconstruction, although we've sort of now gone into the cosmetic space as well. We've been using them for decades for various reasons. But just recently, the FDA kind of came out and said, wait, just so you know, general public out there, we have never FDA approved these in the breast. So all the companies had to dial back what they say about the uses of these meshes until they can get actual FDA approval in the breast, and those studies are ongoing. But when you go to get your surgery and have your mesh, you're going to get a consent form that says off-label use of device. And that's just because there is no official FDA use of these devices in the breasts.
Right. The point being that you can do it. It's not that it's not an FDA approved device. It is. It's just doesn't have an FDA approved indication for that
breast
situation.
And only because nobody's ever
it.
done the study, because we didn't think we needed to. The plastic surgeons have been using these devices for, again, decades, and we know how to use them. We know how to use them safely. We know how to use these devices, and we really haven't had significant problems. But now we are going through the process of actually getting that approval. But that's sort of a caveat that people need to know. So don't freak out if you see that consent form coming at you, off-label use. In medicine, medicines are used off-label all the time. And as long as there's a fairly long-standing history of using them safely, that's enough for most practitioners.
Right. And, how's the FDA going to make money if they don't demand more studies? So that's a big part of it. They got to make their cash. So they say, well, it's already approved for soft tissue reconstruction. But we'd like you to tell us if it's okay for soft tissue reconstruction in the breast, which is what we're doing.
Which is what we're doing.
So you really don't need to do the study. However, again, there's always, lawyers, guns, and money involved in all of it.
And
so
the company
that's the bottom line.
The company that can get that first FDA approval, which is probably going to be Allergan, because they're just the biggest company, then they can go out and say, the only FDA approved device, right? So
of course.
Money. But let's talk about, so that's just like fit or fodder, like who cares? Let's talk about what these actual devices, meshes, matrices, whatever you want to call them, let's talk about what they're used for and why we use them in the breast.
Well, the most common reason that I use them is for some type of pocket reconstruction, whether it's to take care of a bottomed out implant, to take care of a symastia, to take care of, way over dissected lateral pocket.
So pocket control.
It's control of the and I always say this to the fellows and residents, that breast augmentation is a misnomer. It shouldn't be called that. It should be called breast implant pocket creation and control, because that's what you're doing. You'll make a nice looking breast if you know how to make a great pocket and you know where to put it and how to have the implant work in harmony with the chest wall and the breast. And that's all about pocket control. And so these devices are the key in a redo situation. I don't know anybody that would use a mesh like primarily in a breast augmentation for any reason, but some might. Like the person sitting across the table from me. But other than that, I don't know what it would. Well, what would you use this for in a primary? So tell me about that.
Yeah. So when you're talking about pocket control, we're talking about the place where the implant lives. That could be under the muscle, over the muscle. We've had multiple podcasts about that.
Right. Refer back. Please.
Refer back to that. And so I'm going to give you a short answer, and then I'll give you a long answer. Short answer: I would use a mesh for a primary breast augmentation if I'm also doing a mastopexy or breast lift, and they have really crappy, elastic, super loose skin. And I want that skin and that breast and that implant mastopexy construct to stay where I put it. And if I don't, things will start to slide off sooner than I would prefer.
So you're using it for soft tissue support of like the inframammary fold to raise it up the chest wall or something like that?
The inframammary fold, the actual soft tissues of the breast, the actual implant itself. Because for these patients that have really stretchy skin, and some patients just have really stretchy skin, either because of weight loss or just genetics, when you put an implant up against stretchy skin, the implant's
more.
going to fall. It's not going to stay high where you want it. It's going to stretch out the skin. So if you can put that mesh there under the implant, now that mesh is taking the support of the implant, not the skin itself. And so it's more likely to stay where you put it. That's why it's called an internal bra. It's literally supporting the implant and taking the pressure off the skin so the skin doesn't take all the stress and then stretch out and fall.
I could see that. I mean, those are the weight loss patients that
Yeah.
they're the normal anatomy has been just
been-
obliterated by
yeah. Yeah.
the fact that they were the size that they were, and then they've shrunk down so much from their weight loss that now the folds all the ligaments are stretched out.
Yeah.
So in that case, I could see it, but I don't think like the 25-year-old 108-pound gal that comes in for breast implants needs mesh.
No, these are usually patients that also need
That's
a lift.
like a crazy looking,
Yeah.
out of control, difficult case. Which here's where you go, folks. You want you got those issues. Dr. Rovelo,
I'm your girl.
she is there for you, I promise. And you're right; those are really tough because you got to control the pocket. There were like articles, by the way, back in the day that said like, for the weight loss patient, you shouldn't use implants.
Because of these problems.
Right.
They fall, they stretch out. Yeah.
Right, which is why, we and a group at Roxbury, we published, and in fact, the last time I saw that paper referred to publicly, Dr. Felman-Eves, who was speaking at Cedars, put our paper up there. Here's the lateral breast flap. He goes, I love this because this actually helps a lot in these weight loss
Yeah.
patients. And we published a paper on that lateral breast flap with like Brian Dickinson and some other people. And it does work. And I was basically using using a mesh.
The extra skin.
From
yeah.
the extra skin.
Right.
But you're just saying, you go ahead and put the mesh there and use that to help cement the
support things.
fold, in the right place,
Yeah.
or the pocket.
And these things, like I said, they go away, they absorb over time. But so Galaflex is the synthetic version of the mesh. It doesn't come from any kind of live structure. They have studies that look at the actual strength of the soft tissues, and they look at it before the mesh, after the mesh is placed. And after the mesh is placed, even after it's absorbed, the remaining soft tissue is 25 to 30% stronger than it would have been without it. So yes, it absorbs, but that doesn't mean that the benefits of it go away, because what it leaves behind is a stronger soft tissue construct.
Yeah, it's just like, the polylactide that we inject into soft tissue, and it stimulates collagen, and it makes its own matrix. So, these meshes are going to leave behind some stronger tissue that, and it doesn't have to be, like breast tissue or whatever. It just has to do its job, which is hold the implant in place.
Right. And I also will use these synthetic meshes even without implants. So in mastopexies, breast reductions, similar cases where I'm concerned weight loss patients that the breasts will stretch out again, not necessarily to where they came from. They're still going to be more lifted than how we started, but they will stretch and fall over time. I have a certain subset of breast reduction / breast lift patients that are quite young, in their early 20s, and just have super loose skin. And they come in saying they need breast lifts or they need a breast reduction, but really what they have are super low stretched out breasts just from genetic stretchy skin. And in those patients, I really like to use mesh because I know that if I don't, in 6 to 12 months, that skin will have stretched out again. And so I really like using it in those patients, in the weight loss patients that need breast lift, because I think that having that extra soft tissue support is really helpful in maintaining the results long term.
What are the problems that come up with these meshes? Do we need to put drains in when we use them? Tell me a little bit about like the downside to using them, because people do talk about like, oh, we'll just use this or use that. There's more to it than that.
Well, there's more to it than that. So everything we've just been talking about right now are these synthetic meshes. And there's a whole category that we haven't talked about yet, and those are the ones that I called the biologics, or sometimes they're called acellular dermal matrices, ADMs. So these are the ones that come from pigs, cows, humans. Those have a little bit of a different indication for usage with some crossover. So those were initially used in breast reconstruction patients. That's sort of how we developed how we use these meshes. And they were designed because after you do a mastectomy, you've taken away most of the fat and the soft tissue of the breast, and you just have skin left behind. And so these ADMs provide a little bit of extra soft tissue support and coverage to your implant. So it's not just implant right under skin. And we do have data, although some people will contest it, that using a biologic matrix under those conditions, an ADM, has some benefit in preventing future capsular contracture. Capsular contracture is when you get a hardening of scar tissue around the implant. Big problem in breast reconstruction in the early days. And over time, people found that using these biologics decreased that capsular contracture rate. And so that's when using them really took off in breast reconstruction. It also allowed for a sort of more natural looking breast reconstruction.
Yeah, I mean, I think that there's so much literature about using these ADMs in breast reconstruction, but in the cosmetic world, not so much.
Not so much, but it spilled over. So
It has.
we took that data that we have, decreased capsular contracture in breast reconstruction. Well, maybe that'll decrease the chance of my cosmetic breast patient that has had recurrent capsular contracture. Maybe it will help that patient too. So it has sort of spilled over into the cosmetic world in patients that have a risk of capsular contracture because they've had it before. Maybe they've had 1 or 2 surgeries already for capsular contracture, and you really just want to throw the book at them. So one thing I offer them is like, hey, you've already taken this capsule out once before and it came back again. I would highly, highly consider using a biologic mesh in this case because there's a chance that that would be enough to prevent the capsular contracture from coming back again. So in those revision breast cases, I would use more of a biologic as opposed to, say, a Galaflex mesh to support the implant, provide the pocket control, and also theoretically, hopefully, maybe prevent recurrent capsular contracture.
I don't know of data showing the synthetics to be preventative of capsular contracture. Is there? I don't know of it. Doesn't mean it's not there.
I haven't seen the data, but anecdotally, I've heard multiple plastic surgeons saying that they think it might. We are definitely using Galaflex mesh now for our reconstruction, so I've been using it in place of the ADMs. So I think that data is going to come out because anecdotally we've all been seeing that it seems to have some benefit. So that segues us into so what are the complications? Why would I want to use a Galaflex over an ADM? I find that the ADMs have a little bit of a higher risk profile, meaning that the complications are a little bit higher. The complications that I see with the biologics and the ADMs are seromas. So fluid accumulation, for whatever reason, these biologics just like to stimulate the body to create fluid.
Yep.
Not permanently. After a while, it goes away. But for those meshes, yes, I have to put a drain in to collect that fluid. Also, the other reason, if you have, like we talked about, you need these meshes to incorporate into the surrounding body tissues and structures. And they can't do that if there's a wall of fluid between the mesh and the tissue that it's trying to support. So you have to drain that space to get the fluid out so that the mesh can actually touch the soft tissue that you're trying to get it to stick to.
100%.
So you really have to use drains in that situation to prevent the seromas and to make sure that that mesh sticks and actually incorporates.
No painless, drainless.
No painless, drainless ADMs over here. So yes, that's one complication, seromas. And seromas, if they stay there, it can get infected. These are still foreign bodies. And until that mesh incorporates and becomes part of your own tissue, it's considered a foreign body. It can get infected. Unlikely, but it's a possibility. So there's a little bit higher sense of paranoia about the postoperative care of these patients that have the meshes because you have to have the drains, you have to manage them, you have to worry about infection. With the Galaflex mesh, I have historically placed drains, although I'm starting to slowly maybe move away from doing that. I haven't pulled the plug entirely, but the Galaflex mesh just behaves totally differently than the synthetic. And I keep saying Galaflex mesh. I'm just using that. There's multiple ones that are in that same synthetic category. Galaflex is just the most commonly one that we use. They're robust. Like I haven't personally, but I have seen colleagues put a wound vac, like a external vacuum device, directly on the Galaflex mesh when it was exposed, and it just granulated, grew new tissue over it. It closed, never got infected. Like it is a robust structure that just it takes a lick and it keeps on kicking. Like it doesn't care. Galaflex mesh don't care.
Yeah, that's good. Yeah, I like it too. I use it a lot for fold reconstruction. That's probably that's when I'm looking at bottomed out implants. I'm like, all right, let's put some Galaflex mesh in there.
Yeah. It does. It provides that support and structure that you need, especially if the fold, that support structure of the breast has been obliterated for some reason.
Yep.
Putting in a mesh as an extra layer of reinforcement is super helpful.
Yeah. So I think those are kind of the big ticket items for that. I think what's sort of the toughest case that you do with mesh? Because I know my vote for that one.
Mine would be the bottomed out implants. The IMFs are sitting down by the belly button, which is not where they should be. And so trying to get them up, trying to put them in the right place, using the Gallop Flex meshed reinforcement. Oh, and they also have capsular contracture, so you have to take out the whole capsule, and now your pocket is twice the size it was. It's going into the armpit, and trying to make sure that you get that pocket the right size. I mean, these are all the reasons we use the mesh and various permutations of them.
Do you want to know my toughest case that I use it on?
Sure.
Symastia.
Oh, yeah. Oh, I was trying to block that out.
You want to block it out if you're like, how could you not? It's so hard.
It's so hard.
It's so hard. And to me, the Symastias that I do.
Do you want to explain what Symastia is to the people?
Yeah, so Symastia is when the implants are basically in one skin pocket of some kind. They don't necessarily have to be in the actual same pocket. They may be in their own soft tissue, kind of encapsulation pockets, but the skin is off of the sternum. The pocket, it's basically uniboob.
It's a uniboob.
It's
they're
one
connecting
breast.
in the midline. There's no
And
separation.
they connect, enough that it A, looks bad, B, is not controllable. The cleavage is ruined. And so the reason I find Symastia hard is not the actual doing of the repair. It's making it look good. I think it's hard to make it look awesome because the reason you're doing it is to create the cleavage. But to really get the separation, you've got to put some sutures. You've got to put some kind of mesh. You've got to do some things that are a lot, sort of against
anatomic,
having awesome cleavage. And, that's, look at my website, people. Cleavage is like, that's what I'm all about here.
Yeah.
I'm trying to make that, work. And if you do it in such a way that you wind up with a big wide gap between the implants, well, then they're almost like, well, why don't you just leave it the way it was?
Yeah.
So I find Symastia to be a really difficult repair.
Symastia is really hard, and the repair is hard, and even harder is getting the repair to stay and to last
100%.
because the body is going to sort of want to go back to where it was, which is where the mesh comes in again, extra soft tissue reinforcement. Because the implants are going to want to go back like magnets to each other. And the mesh is helpful, but it's a really, that's why I blocked it out.
You did. You didn't even act like, you were like,
Symastia,
I'm gonna talk about that. I'm going to act like it. All right, I'm going to act. I got to hear him say that. What's on your brain right there?
I know. Yeah, that's definitely a tricky
No
one.
Symastia for me, please. Thank you very much. Yep, I'll take the bottomed out implants for $300.
Yeah.
Well, anyway, I think that's kind of our roundup on the meshes. Anything else you need to go over on that?
No, I think that was it. Just want people to understand, when they ask, why we're using this, it's not FDA approved. These are all the reasons, money, money, money. The reasons we use it, the different kinds of mesh. It works. Adds a little bit of complexity to the case, just something you need to be aware of. But I wouldn't be suggesting it in any given situation if I didn't think it added value.
Correct. And I'm pretty... I go to these devices pretty quickly if I know I need them because they work.
Because they work. Yeah. They're not cheap. We should mention that. The synthetic meshes are much less expensive, but the biologics, the Alloderm, Flex HD, Stratus, all of those meshes, you're looking at easily $3,000 to $6,000.
Get out your checkbooks.
Just for the device, not to mention the additional fees to the surgeon, et cetera, for putting it in.
See, but this is where people start getting they get a little bit irritated. It's like, I just wanted to have a breast augmentation.
I know, and now you're telling me it's going to cost $30,000. It's like,
yeah, it does.
Yeah, these devices do add up for sure.
All right. Well, I think that's...
Well, on that depressing note...
I'm going to go do some more work in case I got to buy some mesh.
Seriously. No, we love them, people. We love them. And if you need them, you need them.
You need it.
And I think they work great. All right. Well, that I think is it. This is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.